Welcome to the USMLE Step 2 Success Podcast. I'm Dr. Rajani Katta, author of Success on the Wards, and in this podcast, I share clinical cases with targeted teaching points. This podcast is not affiliated in any way with the National Board of Medical Examiners, and cases and teaching points are not meant to serve as an official study guide or medical guidance. I've been a faculty member for over 2 decades, and during that time, I've advised hundreds of residency applicants. I know how important standardized test scores are, but I always emphasize to my students that they're just one piece of the puzzle. It's very important to learn how to succeed and do well during your time on clinical rotations, not only because of grades, not only because of your educational experience, but also because that forms the foundation for your letters of recommendation and for the comments that go into your dean's letter. If you'd like to learn more about how to succeed in the residency match, you can sign up for a free 100-page excerpt of my book on our website, thesuccessfulmatch.com. You're working a regular afternoon shift at the emergency room when the nurse comes in to tell you about your next patient. She's a 75-year-old woman, and she reports a new onset of headache. As you go in to speak to her, you're struck by a few things. First is that she's a former actress, and she was in fantastic health for a 75-year-old woman. She, however, reports that a few months ago she started to develop shoulder and hip pain, and in fact, it's making it hard for her to get up from out of her chair and even to comb her hair. She describes a new onset headache that's localized to her forehead area. However, she describes that she's feeling tender and pain in multiple areas. She reports that her scalp is tender, and she reports that she has pain in her jaw with chewing. She also describes a low-grade fever, as well as a few episodes of blurred vision that have occurred on and off. As you're speaking to her, what do you think is the most likely diagnosis? Are you thinking about a collagen vascular disease such as dermatomyositis or lupus? Are you thinking about an arteritis such as giant cell arteritis? Or are you thinking about an infectious disease process such as Lyme disease, especially given her low-grade fever? The next question I want to ask is, what physical exam finding are you going to be seeking? You're about to do her physical exam. What are you specifically going to be looking for or paying close attention to? Is it her heart rate and rhythm? Is it palpation of the scalp? Is it palpation of her temples? Or is it a dental exam? And finally, what would be the best initial test? Would the best initial test be a CK and aldolase? Or would it be an ANA or a rheumatoid factor? Or an ESR, an erythrocyte sedimentation rate? We're going to talk about a few different things, but as you were listening to the history, the most likely diagnosis here is giant cell arteritis, also known as temporal arteritis. If you were suspecting temporal arteritis, the physical exam that you wanted to focus in on would be to visualize and palpate the temporal artery. And the best initial test would be to look for an erythrocyte sedimentation rate. Another question I'm going to ask you is, what accounts for her muscle pain and weakness? Would it be dermatomyositis? Would it be polymyalgia rheumatica? Would it be rheumatoid arthritis? Well, let's speak a little bit here about temporal arteritis or giant cell arteritis. There's 5 main criteria for making this diagnosis. The first is age greater than 50 years old. So this is really a disease that affects older individuals and women more than men. One of the other main criteria is a new onset localized headache. There is not really a pathognomonic feature of the headache, but it tends to be either new in onset or a new type of headache. And it does tend to be localized. It doesn't have to be localized to the temples, though. It could be localized to the temples or the occipital area. Another key criteria is that you would experience temporal artery pain on palpation or decreased pulsation. That's why it's so important to examine that temporal artery area. And in fact, ER physicians are often told that when you're evaluating new onset headache, one of the physical exam features that you really need to look out for, or that you really need to perform, is to palpate the temples. Another criteria is an ESR greater than 50, so a really high level of that ESR. Another criteria is a temporal artery biopsy, and we're going to get to that in a moment. So in order to diagnose temporal arteritis, you're going to need 3 or more criteria. So already of the criteria, you've got age greater than 50 years old, a new onset localized headache, and you're about to palpate the temporal arteries and note pain on palpation. The best initial test would be that erythrocyte sedimentation rate because you're looking for that level over 50. In terms of other signs and symptoms that can be seen with temporal arteritis, well, let's start with the underlying pathophysiology. This is a systemic inflammatory vasculitis. So even though it's commonly called temporal arteritis, it really is giant cell arteritis. It involves far more than just the temporal arteries. A systemic inflammatory vasculitis that involves the large and medium blood vessels. So knowing that underlying pathophysiology, you can correlate that with the clinical symptoms. So headache, key criteria, no pathognomonic features. Vision loss is one of the most important things that we think about in terms of complications of temporal arteritis. And on presentation, approximately 50% will describe vision loss. And it can be very nonspecific and it can be on and off. So blurred vision on and off goes along with that. You also frequently see signs and symptoms such as scalp tenderness and jaw claudication. Now, all 3 of those, vision loss, scalp tenderness, and jaw claudication, are related to arteritis. So, if you have posterior celiac arteritis, those are the arteries that supply the optic nerve, and that's why you're so concerned about vision loss. And in fact, temporal arteritis is considered an ophthalmologic emergency because if you're starting to have decreased blood flow to that optic nerve, you can have ischemia and you can have permanent and irreversible vision loss. This is an ophthalmologic emergency. Scalp tenderness, again, because of the arteries that are involved. Jaw claudication, again, because of the arteries that are supplying the jaws. So if the patient reports pain with chewing, that's an important symptom to look out for. Also can see non-specific systemic symptoms, and these are common, such as fever, malaise, and weight loss, because this is a systemic inflammatory process. Less common, but can still happen, are involvement of some of the other large arteries. So you might see involvement of the aorta, the iliac, or the subclavian arteries. Less common, but may be seen. So if you are suspecting temporal arteritis and you've ordered your ESR and you have an ESR that's greater than 50, now you're really coming down to your diagnosis. What is the most appropriate next step? Would it be a temporal artery biopsy? Would it be high-dose steroids? Or would it be a color duplex ultrasound in the emergency room? Well, the next most appropriate step would be to start treatment. If you have met multiple criteria and you're really highly suspicious of temporal arteritis, again, this is an ophthalmologic emergency. An early diagnosis and treatment means that you are going to be able to prevent sudden and irreversible vision loss. So, The first step is to go ahead and start steroids, typically high-dose oral steroids. Once you have the patient started on those high-dose oral steroids, then you can plan to achieve confirmation. The most accurate test, if they ask you this on the boards, the most accurate test would be a temporal artery biopsy. And this test will stay positive for at least 1 to 2 weeks after you start the treatment. That's why you start treatment and get your confirmation afterwards. In practice, however, you could also use color duplex ultrasound or high-resolution MRI to make the diagnosis. That's something that's discussed in the literature. On an exam, the most accurate test would be a temporal artery biopsy. So clinically, once you start those high-dose steroids, it's remarkable how quickly patients improve. Symptoms often improve within days. I also want to ask you about key pathologic features on the biopsy, because this is another potential question that they might ask. Skip lesions are common, which means that you need to have a sufficient length of temporal artery to examine under the microscope, because you might have that skip areas where you have normal pathology next to pathology. You'll see either mononuclear or granulomatous arteritis, and usually you are going to see giant cells. So that's where the name comes from, giant cell arteritis. You will commonly see disruption of the internal elastic lamina. I could see that being a possible board question. And one of the reasons that's so important clinically is because that's why you see so many extracranial symptoms. That's why it's the temporal artery and the posterior celiac artery and the scalp arteries. But that's why you're not hearing about those intracranial arteries. The intracranial blood vessels are usually spared because they lack that internal elastic lamina. And in fact, stroke is only reported in about 4% of these patients, even though this is a systemic arteritis. So that internal elastic lamina is very important. Another question that you might be asked is, what accounted for the patient's muscle pain and weakness? I mentioned dermatomyositis because this patient had a hard time getting up from her chair and she had a hard time combing her hair. And that's something we really focus in when you're thinking about dermatomyositis. But note one key difference. This patient described muscle pain and weakness. So those are really typical history for polymyalgia rheumatica. And when you're looking at giant cell arteritis, about 50% of these patients will report polymyalgia rheumatica. And that may precede, coincide, or follow the diagnosis of temporal arteritis. In this case, this patient probably did have polymyalgia rheumatica for several months before she developed the new onset headache. And it's important to notice that in PMR, your CK and aldolase are typically going to be normal. Actress Barbara Billingsley was famous for her role as June Cleaver, the mom on the famous hit TV show Leave It to Beaver. And I always picture her as being very active and in great shape. But if she was a 75-year-old woman, she really fits that profile of your typical patient with temporal arteritis, also known as giant cell arteritis. This is a systemic inflammatory vasculitis. So that's why you have multiple areas that are involved. It's not just the temporal artery that it's going to be involved. So that's why your typical features are going to be that new onset headache that is typically localized, but your patient may also have symptoms such as jaw claudication, scalp tenderness, and the one that we're worried about so much, vision loss, because you might have involvement of the arteries that supply the ophthalmic nerve. And that's something that's so concerning because you can have sudden and irreversible vision loss once you get ischemia. These patients often have systemic symptoms such as fever, weakness, malaise, and about 50% have or will develop polymyalgia rheumatica, which would then give you additional symptoms of shoulder and hip pain and weakness. One of the key criteria is a laboratory finding, which is an increase in ESR greater than 50 typically. These patients might have an increase in ANA or a rheumatoid factor, but it's no more common in this condition than in controls. An elevated ESR, however, is going to be seen in about 90% for this condition, but you would not see an increase in CK and aldolase, even if that patient had polymyalgia rheumatica. What's the physical exam finding that you're looking for? Well, you're looking for decreased pulsation in the temporal artery, and you're going to palpate that temporal artery because you're looking for pain on palpation. What's going to be your most appropriate next step once you document that elevation in ESR? Well, it's an ophthalmologic emergency, and you're really trying to prevent irreversible vision loss. So you're going to start high-dose steroids. What's the most accurate test? It's going to be that temporal artery biopsy, but you're not going to hold treatment until you get that biopsy, because that biopsy is going to stay positive for at least 2 weeks after you start treatment. In terms of pathology, well, you're going to see skip lesions and a mononuclear or granulomatous arteritis, usually with giant cells, and you typically will see disruption of the internal elastic lamina. In terms of pathophysiology, systemic inflammatory vasculitis of the large and medium blood vessels, typically extracranial, but can involve multiple blood vessels. The good news is that your patient is going to have typically a very good response to treatment, even within days sometimes, and a good long-term prognosis as long as treatment is initiated early.